Hey everybody. So today the topic of discussion will be supraventricular tachycardia. Before that, I want to thank my resident Ram for giving me this very nice, cute, fluffy mic through which I am speaking. I feel the audio quality is better with this. Like the sound is really loud when I hear the playback. Let's see how you guys feel. Okay, so to the topic, supraventricular tachycardia. So what does it mean? When we tell supraventricular, it means it is above ventricle. What is above the ventricle? The origin of the arrhythmia is above the ventricle, either at the level of either atria or the AV node. It's the most common symptomatic arrhythmia in infants and children. Whenever an infant or a child is coming with significant tachycardia, for infant it is about 220, for older children it is above 180, with signs of poor peripheral perfusion in infants, or in older children it can be palpitation, dizziness and syncope and chest pain. Then you suspect, so this could be a supraventricular tachycardia. How do you know? Clinically, child is very tachycardic. Infants about 220, children above 180. Sorry if you are hearing some cough sniffles, it is me. I am having cough and cold. Okay, my son gave it to me, by the way. Onset and termination is abrupt. Okay, so you may get some history, especially in an older child, where they tell, some 2 weeks back I had this sort of pada feeling in the chest, palpitations in the chest, or had some syncopal episode. It could have been the same thing because it just started and stopped abruptly. It went unnoticed. Okay, so when you have this high heart rate and plus or minus signs of poor peripheral perfusion, you suspect, okay, it could be a supraventricular tachycardia. How do you know it's a supraventricular tachycardia? By doing an ECG. When you are doing ECG, what do you see? You see absent P waves with narrow QRS complex and fixed RR interval. There will not be a variability in rate. Okay, suppose two children are having rates of 190, 190. Okay, one child is having fever. This child is crying, calming down, crying, calming down. You will see heart rate going from 190 to 210, 190 to 210 with variable RR interval. So two RRs will be close together, then one will be little far away, the other one will be little close. Okay, and in between two R, there will be two positive deflections. One will be a T wave, one will be a P wave. Okay, so whenever there is variability in heart rate and you're seeing two positive waves, it is more sinus tachycardia. If you are having two positive, two R waves, but only one positive deflection in between the two R waves, then there is no P wave that is sitting there. And if you are having a fixed RR, where whatever the child does, the RR does not vary at all, it points more towards a supraventricular tachycardia. ECG is not just important in diagnosing that this is supraventricular tachycardia. Once you have aborted the SVT, then you can also get to know, is there a pre-excitation component that is sitting there in the heart. And whenever you are having a narrow complex tachycardia, it is important for you to identify whether it is SVT. Once you know it is SVT, you need to know whether it is having good perfusion or poor peripheral perfusion. If it is poor perfusion, it's going to be synchronized cardioversion. If it is good perfusion, it is going to be your medicines that is going to abort your SVT. So what causes this SVT? We just saw that it is above the level of ventricles. Two mechanisms. One is re-entry, the other one is automaticity. When you tell automaticity, it means there is a focus that is continuously firing impulses. Okay, there is enhanced automaticity. So that's ectopic atrial tachycardia, one of the examples. Okay, the other one is in AV junction, there is an automatic focus sitting there, continuously firing impulses. So that's your junctional ectopic tachycardia. This is more common in post-op patients in the cardiac ICU. So this is about automaticity. What is re-entry? Re-entry is patient is having a shortcut. Okay. Shortcut can be either away from your regular road, that is your AV node, or it is sitting within the AV node as an accessory pathway. Okay. So what is re-entrant tachycardia? There can be an accessory pathway or there can be a nodal pathway. Okay. So imagine this is the main road that the person is supposed to go in. Okay, so this is how it is supposed to be. This is how the race is supposed to happen. Okay, suppose there is a fast lane that is sitting there. Like inside the road itself, you are having an area where your vehicles can move faster and faster. Okay, So it can be somewhere, say, okay, my pen is not working. I don't know for what reason. Okay, so this is the road. You're having one part of the road where if vehicles go, it can go much faster than the regular road. Okay, so this is the nodal pathway. So this is functionally separate. Okay, it is not a separate pathway. It is within the AV node, but one is acting as a fast pathway, the other one is acting as a slow pathway. The other one is called as accessory pathway. When you tell accessory pathway, it's an anatomically separate pathway. Like you don't see it as part of this road at all. Okay, so this road is here, but there is a separate path from here to here. And this is the anatomically separate pathway through which vehicles can come fast. So this is anatomically separate. Accessory pathway is anatomically separate. Nodal pathway is just functionally separate. How do you know which is which? You are not going to open the heart and see, no? So a subtle way of knowing it is once you have aborted SVT, you do a ECG, see if there are signs of WPW pre-excitation. Okay. If there is a pre-excitation that is sitting there, it's generally an anatomically separate pathway that is sitting. If ECG is not showing pre-excitation, it's probably a nodal pathway through which this fast firing happens. Okay, so these are all diagrams basically representing different things. So if you look at this accessory pathway, see it's a separate pathway. This egg-shaped thing on this road is your AV node. Okay, but you're having a separate pathway that is sitting here. The terms orthodromic, antidromic just means the direction in which your electrical activity is going. Okay, if it is going from your atria to ventricle in the AV node, it is orthodromic path. If it is happening in reverse, it is antidromic. Okay, so that's about accessory pathway. For nodal pathway, if you see within the node itself, you are having two separate paths that are happening. Okay, and here again, depending upon how your electrical activity is happening, it is named as orthodromic versus your antidromic, like which direction of pathway is finally entering the ventricles. So these are basically expansions of whatever is already told to you. Okay, so this is accessory pathway, reentrant, supraventricular tachycardia, orthodromic, antidromic just means the direction in which it is happening. Okay, idella I will not bore you guys too much, and I don't think it is needed for postgraduate level. If you know to identify and if you know to identify it as a supraventricular tachycardia with pre-excitation, without pre-excitation, I think that's more than enough. What about investigations? Okay, we'll talk about treatment shortly. When you have investigation, what you are interested in knowing? You are interested in knowing, is there a structural abnormality in the heart? Okay, is there a pre-excitation in the electrical activity? Correct. So these are all the things that you want to know. So structurally normal illayana, how do you find out? You do it with echocardiography. Okay, X-ray will just tell you whether there is cardiomegaly that is sitting there, because persistent tachycardia itself can induce cardiomyopathy. 12-lead ECG you do to diagnose one SVT. You also want to know if there is some WPW component that is sitting there. Apart from that, your electrolytes, calcium, magnesium, all of this will form part of workup for any arrhythmia. Further evaluation, if the patient is having recurrent runs of SVT or persistently child is having SVT, you want to do a Holter monitoring to see if they are able to capture these separate events. Because if it is going to be recurrent and it is going to cause functional limitation in the child's life, then we need to find a permanent solution for that limitation. Electrophysiological study, again, if you do not know what is causing this SVT, whether it is accessory, whether it is within the AV node, whether it is outside the AV node, and it's not responding to your treatment, then electrophysiological studies will help you find out what is what and which is which, so that you can narrow down your diagnosis and initiate treatment appropriately. And any prolonged unexplained tachycardia, you need to get a thyroid function test done. So this is how the ECG will look. If you see 2 RRs, there is very similar interval between 2 RRs. There is no variability at all. It is like I have just copy pasted multiple small strips of ECG together. And if you see, there is just a single positive deflection between two RRs that are sitting there. Okay, so this is classical of your supraventricular tachycardia. Nodal reentrant tachycardia, it's more influenced by increased sympathetic tone rather than separate accessory pathway that is sitting there. So, nodal reentrant is more triggered by physical activity, emotional stress, or abrupt changes in body position. Nodal, similarly, is less likely to be incessant. So, it will not happen for a long time. It will not continue to stay there long enough to cause a cardiomyopathy. Generally, younger the age group, it is more prone for a accessory SVT, accessory pathway induced SVT, whereas an older child is more likely to have a nodal related reentrant supraventricular tachycardia. So, differential diagnosis for any child who's coming with fast heart rate, first you need to know whether it is sinus tachycardia or not. If it is a atrial flutter, you will see sawtooth P waves. If it is ventricular tachycardia, then the QRS complex is going to be wide and you might see AV dissociation that is happening there. You will see AV dissociation that is happening there. And if it is ectopic atrial tachycardia, then the P wave axis, you will see changes and there will be rate fluctuations that is sitting there. Okay. So what causes this generally? Most of the times 50% heart disease is not there. Around 20% you can have WPW excitation, but that you will find out only if you are converting back to sinus rhythm. Some congenital heart diseases like Epstein anomaly, single ventricle, LTGA, they are more prone to have this supraventricular tachycardia. And post cardiac surgery, you generally end up having junctional ectopic tachycardias. So this WPW, I kept on telling. So what do you see if it is a WPW? You will see very short PR intervals of less than 120 milliseconds, slurred upstroke or downstroke of your QRS complex, which is called as the delta wave. And you can have a wide QRS complex more than 120 milliseconds. So less than 120 is PR, more than 120 is your QRS, and you will have a slurred stroke of the QRS complex. So that's how you identify a WPW. So how do you treat? You have identified, you will generally treat and then you will investigate. Okay, so that is the order in which a patient management goes. So your line of management will depend on whether the patient is hemodynamically stable versus unstable. Okay, this is acute management. Then after that comes your chronic management. So acutely, if the patient is hemodynamically stable, you can start off on vagal maneuvers with ice bag to face in infants. Don't put on ice, pressure, don't do carotid sinus massage, especially don't do both sides, you will cause stroke to the patient. Okay, older child, you can make them do Valsalva provided they are awake and they are stable. Meanwhile, this most of the times will not abort things. This will just buy time. And you will have to end up giving adenosine. Okay, adenosine, there is a specific way in which to give. We will come to that. Okay, first dose will be 0.1 mg per kg. Maximum dose is 6 mg. Second dose is 0.2 mg per kg. Up to 0.3 mg per kg, you can go. Watch out for bronchospasm. Unstable patient, you need to give synchronized cardioversion. Okay, 0.5 joules to 1 joule per kg will be the first dose. You can go up to 2 joules per kg. Okay, and once you give adenosine and you have terminated SVT, if there is an underlying problem, your ECG will pick it. Adenosine is the drug of choice in a hemodynamically stable patient. Okay, so it has got negative chronotropic, bromotropic, whatever tropy you have read in physiology, all tropy, it is negative. Okay, adenosine will suppress all of that. The problem with adenosine is that it's got a very, 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 very short duration of action, which is less than 10 seconds. Okay, it's both an advantage and a disadvantage. Advantage because not much of hemodynamic compromise you will have. But the disadvantage is that you need to give it really, really fast. So how do you do if a patient is having SVT? If you are already having a central line in situ, then it's easy. You administer the medication through the central line. Okay. If not, you need to put a peripheral line that is close to heart. So choose one of the elbow veins that is sitting there. Attach a three-way. You need to have a simultaneously loaded adenosine and a 10 cc syringe attached to your three-way. You need to have two people administering the medication and one person trying to look at the monitor. Okay. So you will give the first dose, which is 0.1 mg per kg, immediately followed by flush. And the flush has to be a rapid flush. So once you give, what do you expect to see? you expect to see a change in rate and a change in rhythm, with the rhythm converting it into a sinus tachycardia. Okay, if there is no change at all, then there are two possibilities. Either your adenosine has not gone in, okay, because the half-life is very small, it's already metabolized by the time it has reached the heart, or your diagnosis of SVT is not right, okay, because it's not arising from the supraventricular region. It's probably a ventricular tachycardia that you're dealing with, which you thought it as supraventricular tachycardia. Adenosine will not work in those situations. All right. It's not effective for any irregular tachycardia, atrial flutter, ventricular tachycardia. So, those things, adenosine will not help. Okay. And remember to give it by rapid IV push. So, depending upon how the patient is responding to adenosine, you can find out what it is. So, if your termination of arrhythmia with a P wave after the last QRS happens, it's probably a AVRT. Okay, if it is terminating at or with a QRS complex, then it's possibly a atypical AVNRT or a AT. Okay, so this is how you identify, okay, whether it is NRT, AVRT, or it is a atypical one. Okay, suppose the response is no effect. We already discussed that your diagnosis of SVT is not there, or your medication has not gone. If it is gradual slowing of heart rate and again there is reacceleration which is happening, then your sinus tachycardia, automatic focal atrial tachycardia, junctional ectopics are possible. Suddenly it is terminating like a AVNRT, AVRT, depending upon where your complex is stopping. Whether P wave after the last QRS, then AVRT and typical AVNRT are the possibility. If it is QRS termination, then it is atrial tachycardia or atypical AVNRT. So these are all the possibilities. If it is persistent atrial tachycardia, high grade AV block, then it is happening somewhere higher, atrial flutter or some rare types of arrhythmias, which I don't understand for those things. Okay, so this is how adenosine response you will assess. Other medications that can be used is propranolol, especially in the presence of WPW, and IV verapamil. Generally, it is avoided in infants. There are other antiarrhythmics like your procainamide, your amiodarone, which are used for termination. So, adenosine, it is refractory. Then it may respond to procainamide. The dose is 7 to 10 mg per kg in a neonate, which is given over 30 minutes. Older children, it is slightly higher dose, 10 to 15 mg per kg. And you will continue infusion at a 20 mg per kg per minute. Remember, whatever medication you're giving as a bolus, unless the patient has responded to a bolus, there's no point in starting an infusion at all. Patient has not responded to bolus, no? Why will the patient respond to this chutuku dose of infusion that you are giving? Correct? So procainamide, once you are doing this, you need to ensure you are measuring plasma levels when you are completing your loading dose to ensure it is at the therapeutic range. All right. So procainamide can be used safely in patients with WPW syndrome. So it's not a problem. It slows the conduction within the myocardium rather than blocking your AV node per se. So it's a pretty safe drug to use. Amiodarone, it's a very broad acting class 3 antiarrhythmic drug. Okay, so when you are giving amiodarone, it's generally reserved for SVT, which is refractory to your adenosine, procainamide, and all that. It can still be used in patients with WPW syndrome. How do you give amiodarone? You give it as a 5 mg per kg over 30 to 60 minutes. Okay, note when you're giving amiodarone, there can be significant hypotension, very resistant hypotension that happens. There can be bradycardia, there can be AV block, there will be significant hemodynamic collapse also which can happen. So you need to be really, really careful. You need to give this under monitoring. And if the patient is responding to this bolus dose, then you can continue infusion at 10 to 15 mg per kg per day. Okay, it basically prolongs the refractory period of your AV node. That's how this acts. Verapamil, we generally don't use so much. Less than 1 year, we don't use at all because it can cause hypotension, apnea, and bradycardia in infants. Verapamil it's good for terminating SVT in children slightly older. Okay, 0.1 to 0.3 mg per kg you can give. Maximum dose of 10 mg you can give. Okay, but here you will not give it in children who are having or you are suspecting to have WPW syndrome. But the problem is at the onset, nobody comes and tells you, see, I'm having WPW and that is why I'm having SVT. No? So that's why verapamil generally we don't use at all. Gen patients respond very nicely to adenosine and if at all needed, amiodarone or a beta blocker. And once you have terminated the SVT, patient has responded very nicely to adenosine, then you can go ahead with beta blockers. Beta blockers, you can start with oral propranolol 0.5 mg per kg, and then you can continue your maintenance dose. If you want to continue as an infusion, then esmolol is the drug that you want to do. 100 to 500 mics per kg over 1 minute, followed by infusion of 25 to 100 mics per kg per minute. Okay, so this is basically algorithm for what to do in patients who are having AVNRT and AVRT. The acute management is very similar. You don't have to get boggled with so many flowcharts. Hemodynamically unstable, you do a synchronized cardioversion. Okay, about synchronized cardioversion, you can do synchronized cardioversion only in a manual machine. Okay, your automated mode, synchronized cardioversion will not come. And you need to press that sync button for your machine to synchronize and ensure the ECG leads of your machine is connected to the patient. Okay, you can't connect your multi-channel monitor to the patient and expect the defibrillator machine to realize it is shocking at the right place. Okay, it will not be able to do at all. So ECG lead should be connected to the patient, sync button should be pressed, and your shocking dose is half of that of your defibrillation dose. Okay, 0.5 to 1 joule per kg is the dose for synchronization. So once you have done that and the patient has responded, then you will choose a beta blocker if the patient has responded to IV adenosine very nicely. If it is a AVRT, there will be a slight difference depending upon whether it is a orthodromic or a antidromic. Your choice of continuation medication will vary. Generally, by this point, we will consult with a cardiologist and then decide on what next medication needs to be done. Okay, so that's about your maintenance therapy. If it's a structurally normal heart, resolved episode, you can choose to wait and watch. But if it is recurrent or your ECG is showing, say, a WPW or R-on-P phenomena or something like that, then you can choose to put the child on propranolol and you can plan for electrophysiological studies. And if it is going to be recurrent, persistent, drug resistant, then will be the option for catheter ablation, so that this accessory pathway, wherever it is, it's ablated and it does not cause further problems to the patient. Okay, so this is about SVT as a full structured manner. Okay, so in infants, oral propranolol for 12 months is good enough. Beyond infancy, verapamil may be used. Adolescents, if it is going to be recurrent and it is causing functional problem, then you can choose catheter ablation. Asymptomatic patients, ablation is controversial. Okay, so we generally do a medical therapy, wait and watch for a year and then stop and reassess what is happening to the patient. Only if your electrophysiological pathway is saying, okay, so this is the problem that is sitting there in the heart and patient is continuously becoming symptomatic, then we go ahead and choose ablation therapy. Otherwise, your medical management with propranolol as a long-term management is good enough for these patients. Okay, so these are all my multiple references. If you have any doubts, put it down in the chat box. Please don't ask me complicated cardiac questions. Okay, only this much I know. All right, all the best. Bye-bye.